Hi, it's me, Dr. Mohammad Kazafi, and you are watching Dr. Mohammad Kazafi Views, and we are going to start one very important topic of the spine surgery, and it is called the jumped cervical facet. And here I want to present one case belongs to that case or belongs to that topic, and the patient is a 45-year-old female with the history of autoimmune labyrinthitis, and she suffered a ground level fall secondary to the vertigo. She evoked the following morning and neck pain and paresthesia in her left index finger. Post medical history is autoimmune labyrinthitis, seizures disorder, and hypertension. On examination, nystagmus with the lateral gaze bilaterally, decreased sensation in left hand to light touch, and the pain limited left deltoid examination, but otherwise 5/5 strength, and without clonus or Hoffman reflexes. Differential diagnosis here: the jumped cervical facets are due to the traumatic flexion, distraction, rotation injuries involving the cervical spine. So here, as you know, the jump facet, for this thing we are doing the imagings, and the image shows usually the image shows for my patient here the midline sagittal CT illustrate a mild anterolisthesis of C6 on C7, which is consistent with the unilateral jumped or the perched facet joint of the C6 inferior articulating process on the C7 superior articular C7 superior articular process. And they note that there is a fracture line extending through the lateral mass. So the CT angiogram shows no evidence of the vertebral artery injury at the level of this fracture, and these findings are consistent with the diagnosis of the traumatic C6 C7 lateral mass fracture with coexistence breech facet, and the post-operative imaging shows good reduction of the fracture with antero-posterior reconstruction. Further workup I did for this patient, such as the laboratory workup, routine labs, imaging, MRI to assess the ligamentous injury, CT imaging to assess for bony anatomy and to aid in potential operative planning, CT or MRI angiogram to assess the vertebral artery. So the pathophysiology here for the jumped cervical facet occur in the setting of several distraction, flexion, and usually rotation force. A unilateral jumped or breached facet occur under the condition of flexion with a rotational component away from the injured side. Bilateral jump facet occur under condition of flexion and destructive force, and regardless of whether the facet is unilateral or bilateral jumped, these are always considered unstable injury given the degree of the osteoligamentous disruption need to create these injuries. Unilateral jump facet typical cause a 25% subluxation of the superior vertebral body over the inferior vertebral body on bony imaging, and bilaterally jump facet usually cause a 50% subluxation, and the radiculopathy on the side of the jump facet is the most common clinical finding in unilateral jump facet. So we have to understand the jump cervical facet occur in the setting of severe distraction. If there is a severe distraction, you will find the jump facet. and flexion, and usually rotational force. And unilateral jump facet are perched facet occur under the condition of the flexion with the rotation component away from the injured side. And in bilateral jump facet occur under the condition of the flexion and destructive force. So regardless of whether the facet is unilateral or bilateral jump, these are always considered unstable fracture, giving the degree of the osteoligamentous disruption needed to create these injuries. Unilateral jump facet typically cause a 25% subluxation of the superior vertebral body over the inferior vertebral body on bony imaging. So the 25% subluxation is enough to cause a unilateral jump facet, and the bilateral jump facet usually cause a 50% subluxation. So radiculopathy on the side of the jump facet is the most common clinical finding in a unilateral jump facet, and patients with the bilateral jump facet have a high likelihood of the spinal cord injury. And the most jump facet occur in the subaxial cervical spine, but it is important to note that the facet dislocation can occur at the C7-T1 junction, which is why visualization of the level on plain film or CT is of paramount importance. A less severe form of the cervical spine subluxation is known as the perched facet, in which the inferior part of the inferior articulating facet perches on the top of the superior portion of the superior articulating facet and without actually locking into place. So the treatment options here, the treatment option usually involve the combination of the cervical traction followed by an open surgical fusion, and traction is usually done in the awake patient under light sedation with the Gardner's valve tongue, and significant weight may need to be added in order to reduce the jump facet. Occasionally, reduction may not be possible with Gardner's valve tongue, and open surgical reduction may be necessary. So the patient's neurological function should be monitored throughout the procedure. Open cervical fusion usually follows reduction with traction, and the controversy exists over the ideal operative approach, and it's decided on a case-by-case basis. A combination of the anterior only, posterior only, or the combined anterior posterior approaches are frequently used, and traumatic disc herniation seen on preoperative MRI require anterior approach to address the patient with traumatic disc and the unreducible locked facet unable to reduce using Gardner's valve traction, and may require a front approach in which the disc is removed and the patient is turned prone and fused from behind, and the front is then reapproached with the placement of the interbody spacer in the previously removed disc space. This approach prevents worsening central canal stenosis from a herniation disc with the facet are relocated from the posterior approach, and it also helps mobilize the spine during the posterior approach. For the anterior cervical discectomy, corpectomy, the patient is positioned supine. Additionally, the patient may be placed in a traction to aid with alignment and intraoperative fluoroscopy, and it used to ensure good alignment before skin incision. Intraoperative neuromonitoring should be used to assess neurological function while under anesthesia. A combination of blunt and sharp dissection is carried down to the prevertebral fascia, and intraoperative film is taken to ensure the appropriate level is or exposed, and the discectomy is performed. At this point, the incision may be closed and patient turned prone if a front approach is used. Otherwise, if there has been reduction in the lock facet with traction in interbody device, autograft, and the allograft may be placed in the disc space. So depending on the type of the interbody device used, a plate may be secured to the adjacent vertebral body to prevent graft extrusion and aid in the fusion. For posterior instrument fusion, the patient is placed in the Mayfield head holder and turned prone or chest roll. The patient is placed in a slight reserved trend lumbar with knee flex, and before skin incision, lateral fluoroscopy is used to ensure adequate alignment. The fracture level and the several segments above and below the injury are exposed, and the jump facet will be apparent after the exposure. Meticulous removal of the superior facet involved in the jump will allow to reduce the lateral mass. Screw are placed above and the below fracture segment, and the rod is locked in the place. The cortical bone of the lateral mass is decorticated. Autograft and the allograft are placed over the decorticated bone to aid in bony fusion. So, before the placement of the traction, craniocervical junction instability should be ruled out. Atlanto-occipital dislocation is a firm contraindication to the cervical traction. Atlanto-occipital dislocation is a firm indication, and it is a firm contraindication for the cervical traction. So avoid it. And combined anterior and posterior approach may provide additional stability in case of the significant displacement or angulation. They may also be necessary to allow reduction of the jumped or perched facet in some case. And the point of the appropriate starting point here, if we may know that the determined by creating an imaginary X over the lateral mass, and the superior and the inferior boundaries are the facet joint, and the medial and the lateral boundaries of the lateral mass serve as the other boundaries, and the ideal starting point is a 1 millimeter medial to the middle of the imaginary X, and the direction little upward and lateral. It will give you the good lateral mass screw fixation, because the lateral and above will give you the certain and strong bony purchase when you are going through that, and it will and you can avoid to injure any nerve or injure any vessel. Vessel means, for example, artery or vein. An up and out technique is used to the handrail trajectory and the medial to the lateral trajectory at 30 degree. Avoid injury to the vertebral body, and cephaled caudal trajectory at 20 degree. Avoid injury to the nerve root. So this 20 degree trajectory from the cephal caudal trajectory is very, very important to avoid the nerve injury, and medial to lateral trajectory at 30 degree. Avoid the injury of the vertebral artery. So you can avoid the vascular injury and you can avoid the nervous injury. So it is very, very important thing. And we have to understand here that the medial trajectory risk in injury to the vertebral artery. Failing to aim the cephal places the nerve root at risk, and starting to far lateral wrist fracture of the wrist fracture of the lateral mass. So that far lateral should be avoided. Imaging of the entire cervical spine, include the cervicothoracic junction, should be obtained giving the relatively high frequency of adjacent bony injuries, and pre-operative MRI imaging, if available, can help determine the length of the fusion required if posterior approach are used. Longer fusion may be necessary if there is a significant posterior ligamentous injury. So here I want to I want to present a little more about not only about the case, but about the topic. And you know that the cervical facet dislocation or fracture represent a spectrum of the traumatic injury with varying degree of cervical instability and this risk of the spinal cord injury. So diagnosis can be confined with the radiograph or CT scan, and MRI should perform before surgery to identify an associated disc herniation, and treatment usually involve closed or open reduction followed by the surgical stabilization. And epidemiology here, you know, the demographic high injury trauma in young motor vehicle accident and motorcycle accident are high speed deceleration injury, and the contact sport injuries, or the low injury trauma in elderly. And the 17% of all injuries are fracture of the C1 or the dislocation of the C7. For the 17% of all injuries are the fracture of C7 or dislocation at the C71 junction. This reinforced to need to obtain radiographic visualization of the cervicothoracic junction. Etiology here definitely represent a spectrum of the osteoligamentous pathology that include the facet fracture, more frequently involve superior facet and may be unilateral or bilateral, and decrease the threshold for the facet dislocation, and loss of tethered facet of the interlocked facet. Unilateral facet dislocation most frequently missed cervical spine injury on plain X-ray and lead to the 25% subluxation on X-ray, associated with the monoradiculopathy that improve with the traction. Inferior facet of the cephalic vertebra encourage the neural foramina. Bilateral facet dislocation lead to 50% subluxation on the X-ray. Unilateral facet dislocation lead to 25% subluxation on the X-ray. So the most frequent mid cervical spine injury on the plain X-ray. So associated with the monoradiculopathy that improves with the traction, and inferior facet of the cephalic vertebra and encourage the neuroforamina. In bilateral situation, as I mentioned, you lead to 50% subluxation on the X-ray and often associated with the significant spinal cord injury, mean in the 80% of the cases. And the flexion and distraction for an element of the rotation, and the rotational movement associated with unilateral facet dislocation. So associated injuries such as the head injuries or the non-contagious spinal injuries often occur in the thoracolumbar, cervicothoracic, and occipitocervical junction, and appendicular injuries. Here I want to show you the classification. Descriptive classification: subaxial cervical spine injury include the compression fracture, burst fracture, flexion distraction injury, facet dislocation, unilateral or bilateral facet fracture, more commonly used in the clinical setting. So the classification definitely here very important. And disruptive classification: subaxial cervical spine injuries include compression fracture, burst fracture, flexion distraction injury, facet dislocation, unilateral or bilateral, and facet fracture, and more commonly used in the clinical setting. So the flexion compression, vertical compression, definitely it's very important that to know, but it is also important that I want to conclude this topic just telling you that the perched facet is a vertebral facet joint where the inferior articular process appear to sit perched on the ipsilateral superior articular process of the vertebra burrow, and any further anterior subluxation will result in dislocation, with one facet jumping over the other and becoming locked in this position. And unilateral perched facet results from the hyperflexion, lateral compression, and the rotation of the cervical spine in motor vehicle accident. So the perched bilateral facet are also possible, and there, and radiograph, plain radiograph, actually the malalignment of the lateral mass and the tip of the adjacent facet touch each other, and the inferior articular process of the vertebra appears to sit perched on the superior articular process of the vertebra below. So the distraction facet with uncovering the articular surface, and this is showing in the CT scan, and the complications are such as the spinal cord injury, especially in the bilateral involvement or in setting of the canal stenosis. Vertebral artery injury, dissection, thrombosis, it can happen. So these things, and is very important regarding this, and we can say the perched facet regarding the radiological point of view. But as you know, the perched facets and the perched facets and injuries are unstable, and we have to need to operate, and sometimes we have to operate means from anterior posteriorly, and the perched facet joints are the vertebral facet joint whose inferior articular process appear to sit perched on the on the ipsilateral superior articular process of the vertebral below, and any other anterior subluxation will result in dislocation with one facet jump over the other and becoming locked in this position. So this is all you can approach anteriorly, posteriorly, both. I hope you will like it. I hope I just put some light over it, and it is a common listhesis area C5, C6, and one of the inferior articular facet of C5 is slipped in front of the and is lying to atop of the superior articular facet of C6, and you know that it is the cervical tongue is contraindicated if there is atlantoaxial dislocation or instability, and when these facets or jump facet are unstable injuries and need the surgical treatment most of the time. Thank you so much. I hope you will like it and you will appreciate by supporting and sharing this video. Thank you so much.